Ladies and gentlemen, very good afternoon to you. Hello, hello, hello. How are you doing? Good afternoon. Thank you. Now, I would love to request that we all move closer. We've got a lot of empty seats on the lower ground. The people seated up, could you kindly come down? We'll appreciate that. Let's fill the seats, the empty seats on the floor, kindly. Please do that, then we can kick off the program. Help me out. Yes. All of you seated in the higher section, if you could just do me that favor. Do me that favor. Let's come down and fill the vacant seats on the ground. Thank you. Let's reserve those seats for the latecomers. Yeah, you don't enter the room early and then take the seats meant for the latecomers. Welcome to the 12th EDCTP FORUM. This is D-Day. We will have our opening ceremony, but we are honored to have you for this pre-event that has been organized by the Rwanda Biomedical Center. Thank you so much for being here. For those visiting Rwanda for the first time, murakaza neza, we're very happy to have you here, and we do hope that you will enjoy your stay. Thank you. Thank you. The title for this event, look at me giving the title before I introduce myself. My name is Jackie Lumbasi, and it's an honor to be your MC. Now, the title for this event is Leading Health System, Transformation Through Research, the Role of National Public Health Institutes and Partner Research Institutes. And to officially welcome us here and give the opening remarks, I would love to invite the Deputy Director General of Rwanda Biomedical Center, Janine Muhire, for her remarks. Please, let's put our hands together as Janine comes on stage.
Thank you, Jackie. Good afternoon, everyone. Muraho neza. Muraho neza. Well, ladies and gentlemen, distinguished guests, it's a pleasure to welcome you to this event and to this important session. We meet at a time when climate change and emerging infectious diseases reshape global and continental health landscape. These challenges test our resilience, but also offer opportunities to enhance health systems through research-led innovation. Today's session builds on that momentum. It highlights how the Rwanda Biomedical Center, RBC, the University of Rwanda, and partner institutions are applying research across the spectrum from epidemic preparedness, operational research, to vaccine development and domestic biomanufacturing. Over the next hour and a half, you'll hear from visionary leaders, concrete stories and practical approaches that translate evidence into public health impact. Let this session and the broader forum serve as a platform to deepen collaboration, catalyze innovation, and commit to sustained research investment. The 12th EDCP Forum features a range of significant events, including plenary sessions, discussions, and scientific symposia, such as how clinical research innovation improves health system capacity in low research settings. Additionally, the forum includes workshops focused on capacity building and ethical excellence in clinical trials. Our collaboration with EDCP exemplifies the forum's overarching theme, better health through global research partnerships. EDCP's investments have boosted African-led clinical trials and regional capacities. I encourage you all to bring your ideas, your questions, and your energy as we explore how to translate research into policy, practice, and impact. Together, we're shaping a future where African-led research drives global health progress. Following this research, you're warmly invited to RBC's exhibition stand where you experience compelling real-world projects that are transforming Rwanda's health landscape, many enabled through EDCP-supported partnerships. I hope that you have a productive session today, but also hope that you're going to build on this session to build valuable connections and share commitment together to transform our health systems. Thank you all.
Thank you very much. Let us appreciate Jeanne Muhire once again. The Deputy Director General of RBC. She has invited you and encouraged you to bring into this forum ideas, questions, and energy. She's also invited you to visit the exhibition stands. Please do. And while you're at it, build valuable connections and share commitments. Thank you so much, Deputy DJ. And now, ladies and gentlemen, we will get to the next phase of this program. I want to invite the co-chair and co-chair, the chair and the co-chair of this pre-event to take over. I would love to call forward Albert Tuyishime of RBC and Nadine Rujeni from the University of Rwanda. They will be taking on from here for the next session.
Thank you so much, Jackie. So now it's my pleasure to introduce the first speaker. So we have a group of speakers who are going to give us some highlights on this health transformation that we're looking forward to. The first speaker is Dr. Albert Tuyishime, who is the head of Disease Prevention and Control Department at the Rwanda Biomedical Center, and a seasoned medical doctor with MSc in epidemiology with over 15 years of expertise in health programs design and monitoring and evaluation, public health surveillance, and health system strengthening. So Dr. Albert, very welcome. You have 15 minutes of your presentation. Thank you very much.
Thank you very much, Prof. Nadine, for the introduction. Good afternoon, everyone. Good afternoon. That's better. So it's a pleasure for us to share some thoughts around building national and regional capacity in terms of research, but also a response to pandemic and outbreaks. May I have my slides? So first of all, as a quick background, we all know our world now is very well interconnected, which unfortunately makes it easier for diseases to spread and then makes it hard for our public health, economies, and security. Secondly, we all know that in order to have an effective response to outbreaks, we need a certain number of elements, among them skilled personnel, coordinated response, as well as research, because whatever we'll be implementing or we have to implement has to be evidence-based. Thirdly, we all know that in order to better detect, prevent, and control infectious diseases, in this case, outbreaks or pandemics, we need to have strong evidences, which will help us in putting in place self-reliant health system. In the next couple of slides, I'm going to share with you what we went through for the last 7 years, closer to the last decade. in terms of outbreaks we experienced here in Rwanda, but also some outbreaks we had in the region, which dictated what we had to implement in order to detect, prevent, and control. So starting with 2018, in August, that's when we had the second largest Ebola outbreak in DRC, which is one of the neighboring countries for us. With this outbreak, we had to make sure we are putting in place a well-established surveillance system that was meant to make sure we are ready to detect on time if any case was crossing the border. Whatever we did back then in 2018 informed what we did when COVID-19 was coming in. And this was in 2020, in March. Exactly, it was on 14th, that's when we recorded our first case here in Rwanda. So whatever we did after that was really informed or strengthened by the experience we had when we put in place the surveillance system following the Ebola in DRC. After putting in place that system, surveillance system, you all know we had to implement a number of interventions that led to starting vaccination, and then at the end, it was in 2023, that's when we had WHO ending COVID-19 as a public health issue then. But right after the COVID-19, we had again Ebola outbreak in DRC, which means we had to make sure our surveillance system is still up and ready to serve the purpose for the Ebola in that case. And last year in July, you remember that's when MPOX kicked in. Africa CDC and WHO both, they declared it as a public health emergency for the world. And in September last year, that's when we started vaccination for MPOX, but unfortunately, we had Marburg here in Rwanda. We put in place our response to both Marburg and MPOX, which was a bit complex because of the two concurrent outbreaks. But fortunately, by the end of 2024, Marburg outbreak was declared over here in Rwanda. But 1 month later, we had 2 outbreaks in the region. We had Marburg in Tanzania. We had Ebola outbreak in the northern part, now in Uganda, which means we had to keep our surveillance system ready for both outbreaks. Now, with this kind of history of what we went through as a country, but also as a region, we wanted to give you a flavor of what the Rwanda Biomedical Center deals with on a daily basis. But before or after that, I will talk a bit about the Rwanda Biomedical Center. So the Rwanda Biomedical Center is an implementing arm of the Ministry of Health, which means the ministry put in place policies, and then RBC comes in just to make sure those policies, they are translated into strategic plans or operational plans, and then implemented effectively and efficiently. So that's the mission for the RBC. And the vision for us is to become a center of excellence for the prosperity of the country, ensuring quality health service delivery, education, and research. With RBC in place, but also making sure we are aligning with the national health priorities, we wanted also to share with you some milestones we recorded over years. So if we take our starting point as 1994, that's when we had the genocide against the Tutsi here in Rwanda that destroyed everything, including the sector, the health sector. So following that event, the government worked tirelessly to rebuild the country, to revamp or to re-put in place the health sector, starting with infrastructures, human resources, supply chain system. And after a couple of years, we had some milestones. One of them would be what we had back in 2002 with the life expectancy moving to 52 years old. If you look at the life expectancy in 1994, it was not more than 45 years. So coming from less than 45 years to 52 years, just after 8 years, means a lot have been implemented. 9 years later, that's when the RBC has been created, and it was created from different standalone institutions, moving from the national HIV program, national malaria program, the national reference lab, putting all those institutions together under one roof to create the Rwanda Biomedical Center. And this was meant to make sure we are being efficient, sustainable, but as integrated as we could. And on top of establishing RBC, one of the key initiatives that was initiated in that year, that's when we started the HPV vaccination to fight against the cervical cancer that is one of the killing cancers for our women. A few years later, in 2015, we recorded a 58% reduction in maternal mortality from 2010 levels. And this was following a lot of efforts around quality improvement, around the capacity building of healthcare providers, around availing infrastructure and appropriate equipment. 2016, one of the key initiatives we started was the implementation of HIV test and treat together with the DSDM, and this was meant to help us fight the HIV we had as a priority in the country. In 2021, when we had COVID-19 pandemic, we managed to contain it or to respond appropriately to this pandemic. And this, as I said, was built on the experience we had from previous outbreaks. And 2 years ago, that's when we relooked at the life expectancy, which now is at 69.6 years, coming from 52 years back in 2002. In 2023, that's when we had the highest percent reduction in malaria cases. That's when we registered 85% reduction in malaria cases from the peak we had in 2016. And last year, that's when we responded to MVD outbreak. On this journey, we are keeping in mind the targets we are having for 2030, where we have a lot of targets in terms of containing diseases, but also improving the health of our population. Here, we highlighted the end AIDS target we have for 2030. We highlighted the elimination of cervical cancer. We also keep on our radar the maternal mortality rate we have to keep decreasing, because we believe every life from our mothers or our women really matter. So this is a summary of the journey we went through right after the genocide against the Tutsi. And throughout, RBC played a key role in order to reach those achievements. However, we still have some challenges. As you understood, the Rwanda Biomedical Center serves as the National Public Health Institute. And when we are implementing our programs, we have a couple of challenges we wanted to share with you so that we can reflect on them and exchange and see what we can learn from each other. The first challenge is around the gains we've been making. Now, when we are going back and look at key indicators from the diseases program, we are seeing a kind of a plateau, which means probably the interventions we've been implementing, they have given what we expected from them. Therefore, we need to find new interventions which have to be evidence-based. Again, reinforcing the rationale or the motivation of having this kind of gathering. The second challenge is about the gaps we are still having in the service provision. And these gaps, they are mainly in diagnostics and treatment, especially in some programs such as mental health and non-communicable diseases. Because for the last 15 to 10 years, we focused more on infectious diseases and maternal and child health. Now, these new programs or priorities need to be considered in our plans. The third challenge is around the evolving landscape or epidemiological dynamics. We used to deal with infectious diseases, now we have to deal with non-communicable diseases due to the shift in diseases burden. But again, on top of this, we are having resistance from different pathogens. You understand, this brings in other considerations, or we need to refocus our interventions or priorities. The fourth challenge we have is about external support or funding, which is common to different African countries. And this is coming where we have to deal with priorities which are more expensive. So this calls to all of us, either to find new funding opportunities or to find appropriate cost-effective interventions. The fifth challenge we have is about talent retention. If you look at our human resource for health, the country invests a lot in building their capacity, but we still have a kind of them leaving earlier or them going out looking for other opportunities, which causes a challenge in terms of programmatic implementation. And lastly, we have to respond to new expectations or needs, research and development. So there is a growing need to do more research, to generate more evidences, but also to develop or strengthen local production of pharmaceuticals and other medical technologies. So those are kind of challenges we are having, but we know even from other national public health institutes, you might be having the same or different challenges which calls to collaboration and working together so that we can address those challenges. At RBC, one of the key priority for us, it's about building capacity, but also leading evidences generation. The way we are doing this, we are putting in place strong systems to help us collect high quality data that are going to help us generate more evidences to inform new policies which will guide the strategic plans or the plans we will be implementing, but also we will be using when mobilizing resources. When we look at the national priorities we have in our sector, in the health sector, we have identified key areas where we have to focus on implementation. And these are the top 10 priority or key areas where we want to focus, or the funding that is helping us, in the implementation of research. You can see NIH was coming on top, followed by USAID, then Bill and Melinda Gates Foundation, and Global Fund. But looking at this, it's again a call to us to find more resources and more partners to help us doing our research. And this is the output from the research. You can see in terms of scientific publications, the Rwanda Biomedical Center managed to put out. We can see a significant increase in terms of numbers for the last 4 to 5 years. And the topics, they are different, but we are also aiming at looking at other topics not yet on this list. The Rwanda Biomedical Center, again, is striving to lead the public health research and capacity building in Rwanda, but also beyond. And that's how we've been working on different initiatives, also regional, keeping in mind that all we need is to generate meaningful results or output to inform the improvement of the lives of our countries. So this is some of the few initiatives we've been working on. The first one is an initiative around transforming the RBC into an excellence hub for national and regional public health institutes. The second one is an initiative to empower community health workers using or through an AI-assisted system. And we have different partners being national, but also international or regional. And we have also initiative around transforming RBC into a center of excellence for national public health institutes. We are working on this together with the Africa CDC. During that journey, I tried to summarize. We've learned some lessons. One is about partnership. Here, using an example of the Marburg vaccine. If you remember, we had this outbreak in September last year, 2024. That's when we declared Marburg virus disease outbreak in Rwanda. It was on 27th. The same day, the government of Rwanda, through the Ministry of Health, contacted or got in touch with the CEPI and Sabin Vaccine Institute to discuss and see or explore ways how we can have access to the vaccine. 5 days after that contact, RBC submitted a protocol to the National Ethics Committee. The following day, the National Ethics Committee was approving that protocol. The following day, we got approvals, different approvals that was needed to make sure we can ship those vaccines. And then the following day, on 5th October, the shipment of the first batch of 700 doses arrived in country. From the declaration of the outbreak to the start of the vaccination, it took us only 10 days. And this was made possible only because of partnerships, being national, working with different institutions, or international, working with different partners. So this is the first lessons we learned from the outbreaks we had here in our country. Secondly, the second lesson we learned is about risk communication and community engagement. We learned that we have to focus on this in order to move our communities from the beneficiary status to the active actors, if I would put it that way. Because one, it's going to ease the implementation. Secondly, it's going to help in terms of having different perspective, not only from the provision side, but also from the demand side. So in our case, we try to use different platforms we have in the country. One of them is on the right side. We have what we call National Community Service. It's happening every month, the last Saturday of the month, where we are having people coming together, mainly to do community work. And for us, we use that opportunity to educate or to provide the right message in terms of health programs implementation. The third lesson we learned is about keeping innovating, keeping in touch with the latest tools in terms of equipment, in terms of applications or methods we are using, but also keeping an eye on the data and look and try to understand what data is telling us, because from that's when we know what we have to do to effectively and efficiently implement. The fourth lesson we learned, which is closer to partnership, we learned that it's not good or helpful to strengthen internal capacity only. Because when I started, I talked about the interconnection of the world. So if you have internal capacity only and you don't have enough capacity at regional level or at global level, you can't expect to, at least to have a successful response, in this case, in terms of health security. So RBC is working around a number of initiatives internally at continental level, but also at global level. And lastly, we wanted to stress on the role of global partnership. Partnerships such as partnership with EDCTP, WHO, or any other global institutions or agencies. Because we believe and we've seen what we can get from these kind of partnerships, global partnerships. It's all about international collaboration, sustainable partnerships, exchange of expertise. It's through those global partnerships where one can mobilize different resources needed, not only funding, but also that's where you learn from different innovations or any other tools. And then from those partnerships, that's where we have capacity building opportunity. And finally, we have seen that from those global partnerships, you can get promotion of leadership, or you can strengthen the leadership of different countries. And all of this, they lead to a strengthened global health research area. We also know what we have to do from the challenges we shared with you, from the lessons learned. We know what we have to do to make sure we are advancing the health security in Rwanda, but also on the continent level. We have to invest in national research infrastructure and capacity building, which has to be a continuous effort. Secondly, we have to create adaptable and scalable platforms for emergency response. Again, we have to implement multi-sectoral diagnostics capacities for One Health surveillance, because we used to focus on human health, but now for the last 2 decades we've seen we have to put more efforts on One Health approach. Fourth, we have to strengthen risk communication and community engagement, as I said. And finally, we have to make sure we are putting in place a research ecosystem that is integrated and resilient, which will be able to support us in the rapid response. We are dedicated to partnerships, as I said, to work together with everyone at regional level, but also at global level, on the epidemic research, but also on the response side. We believe building capacity for today is going to serve us tomorrow, because we don't know what's coming tomorrow, which is going to require additional capacity of what we have or of what we had yesterday. And finally, collaboration remains the key to success. We invite all of you, partners, stakeholders, to join us in this journey we started, which has beared some fruits, as you've seen. But if we work together, we believe we can achieve more. We can not only strengthen the Africa health security, of course, through shared research and innovation, but also will be contributing to the global health security. I thank you very much.
Thank you very much, Dr. Albert. I think this is a very wonderful talk, highlighting the wonderful journey of progress from a life expectancy of 52 to nearly 70 in about 30 years. So, and this is really a call to partnership, a call to collaboration, and a call to think beyond the normal, the business as usual in research and capacity strengthening. So allow me to introduce the next speaker, who is Dr. Clarisse Musanabaganwa. She's a distinguished medical research analyst at RBC, and she's doing currently a joint postdoctoral fellow at Brighton Sussex Medical School and the University of Rwanda, and she earned her PhD from Radboud University in the Netherlands. Very welcome, Dr. Clarisse.
Thank you, Chair. Good afternoon, everyone. As an add to the previous speaker, I'm very pleased to take you through how operational research has been driving change through the implementation of healthcare programs in the context of Rwanda. So before I go deep on that, I wish also to take you through the epidemiological trends of Rwanda, as you've seen in the previous presentation. Rwanda has done a great job in terms of reduction of mortality due to infectious diseases and also maternal and child mortality. And also, as you observed, Rwanda's life expectancy has increased tremendously to the lowest point of 1994, where we had the life expectancy of 14 years. Now we are at 69 years. On top of that, also one example of HIV, which is one of the matured program we have, we had a success in the declining new infection at 82%, and also declining mortality due to AIDS at 86%. However, as you've heard, NCDs is becoming really a burden for the country like any other African countries, where now NCDs is, mortality due to NCDs is taking over and is increasing over years. And this has really pushed our government to think about scale up of healthcare services, where now we are trying to scale up NCDs healthcare services across the countries, and prioritizing cancers and cardiovascular disease among the top NCDs to fight. So as you've seen also, RBC has a mandate to lead implementation of healthcare programs from infectious diseases to NCDs and biomedical services, with a vision to really make our Rwandans to access healthcare, quality healthcare, through data-driven policies and evidence-based healthcare. So why do we invest in operational research? We invest in operational research first to identify gaps in service delivery, and we adjust as the program mature, and also test the scalability of those solutions which are feasible, and also keep informing the national health policies according to what works and what gives promise. We have many strategies that we apply to really embed operational research in our routine activities. First, we use routine data systems, where we have different platforms that collect data on a daily basis. To name some, DHIS2, NCD Tracker, EMRs, HMIS, etc. All these are being used on daily basis to keep tracking the progress and effectiveness of interventions. And also we adopted approach of building in operational research in programmatic interventions and routine activities, and community and stakeholders engagement through what we call technical working groups per areas of interest. And then also partnership is the key. As you've heard, we partner with private sectors, development partners, and academic institutions to make sure that we keep identifying research questions, operational research questions that can be answered and improve our program. Of course, also, we don't forget local capacity building. We have different programs that will put in place to build our capabilities to do research, operational research methods, and also data analytics. Many health outcomes are intended, such as increasing high screening coverage, real-time quality feedback, identifying barriers that inform adaptation as we progress, multi-sector partnership from mapping to treatment navigation. So how do we integrate those operational research activities in the health program? I prefer to give an example of HIV care retention. That's where we had really a great, we have many success, but that's an example of one of matured programs in the country, where HIV care retention is at 93%. And one of the many pillars which driven to that success was on routine data collection. We used to do routine data collection keep checking different indicators, and also together with partnership with DPs, and also building capacity building. And at the end, we reached that success of 93% of care retention. Not only that, also some evidences where we did different operational research studies. Life expectancy for people living with HIV has increased to additional 25 years due to increase of access to ART. And as you can see, according to WHO, it is expected that people living with HIV with CD4 greater than of 500 cells count were expected to have increase of life expectancy. And since we increased access to ART, this is how the CD4 cell count for those patients has increased over years. Not only that, we also kept identifying factors that may be associated with new infections, HIV new infections in Rwanda. And with that kind of research, HIV program has been able to integrate or to add additional intervention targeting high-risk group, which was a younger female. Again, another good example is treat-all implementation. Also, we did a quick research in our health facilities at primary healthcare level in 10 health facilities. And when we started treat-all implementation in those 10 health facilities, we were surprised with what also the life expectancy increased to 25 years. And also, we've been able to surpass even UNAIDS 1990 targets. 94% of people who were diagnosed, 91 of them accessed ART, and 90, the viral load was suppressed. Coming to malaria, this is also another quick example how we choose to have evidence-based interventions, deployment, tailored to population. Like this research was done to evaluate how LLIN durability according to 3 years cycle was being effective in our setting. And this research has shown that the survivorship of LLIN was estimated to 75%, but considering integrity, it declined to 42%, which really also guided the program to update the social behavior change package. Another good example is on the use of BTI application in vector malaria control strategy. This was done in one of our area here in Rwanda, and this research also highlighted the importance of larval source management and engaging community in that process. This research again has informed our program to scale up BTI application among vector control strategy, and this again we expanded the program and we moved from hands-on technology to drone technology. And we spread this BTI application using drone, and it shows a significant improvement in reduction of mosquito densities. Another important operational research, how it helped. Recently, Rwanda has adopted malaria home-based program where community health workers are supporting in early detection of malaria cases. And when we evaluated how those programs really improved the reduction of severe malaria in the community, again, we observed a really high level of malaria, severe cases, and simple malaria in the intervention sites compared to the control site. Again, this promise that community health workers model works well in supporting in public health. Another important evidence where we packaged together for evidence-based intervention for malaria is on malaria resistance, where K13, when K13 mutation was detected, identified to mediate artemisinin resistance. Again, our program has adopted and changed some of the interventions, for example, from shifting from standard nets to other different types of nets, which are more effective. Another example on TB treatment outcome, how they improved. There's one program which we called One-Stop TB HIV Services, which was implemented in 2000. So there is a group which did evaluation on that. And from that study, TB program has been able to shape or to update the national policy and also improve treatment outcome for TB patients. Continuous surveillance of resistant TB burden in Rwanda also has enabled us to document on rifampicin-resistant prevalence in the country, and also having routine data collection on that. Also, different evidences, such as showing that reduction in diagnosis and treatment of delays reduce rifampicin-resistant tuberculosis mortality, is one of also interesting research which informed the program to introduce TB case finding intervention in our community. Coming back to maternal health outcome, also we did well. Severe maternal outcome were identified through operational research projects, and due to this evidence, we've been able to upgrade some of our health facilities from district to primary healthcare level, and also increase blood banks in that health facility to reduce the severe maternal health outcome in the country. Also, some influencing factors for PPH in Rwanda have been identified, and this has enabled maternal and child health program, which is in RBC, to scale up PPH bundle, postpartum bundle, to ensure that some of the products are distributed through antenatal services. So on under 5-year mortality, also we did a lot, but I mentioned some of the interesting programs, such as introduction of rotavirus vaccine, which started in 2012. And this, together with PMTCT program, has really led to the reduction of under 5 mortality in the country. Quick example, this is one of the studies which was conducted to check how the hospitalization admission due to diarrhea has reduced over years after the introduction of rotavirus vaccine. As you can see, there has been a clear reduction from 2012 to 2014. Many other factors were studied toward the elimination of really PMTCT in the country, and different interventions were introduced, such as program targeting malaria and others. Coming back to NCDs, we also, as you've seen, now we are starting to fight NCDs, and it's one of the, it already has overtaken infectious diseases. As you can see, causes of death due in the health facilities, 46% are due to NCDs. And RBC's response has been more on national NCD strategic plan, establishment of that plan, community-based screening, and promotion of evidence-based interventions through research. Again, in this program, we adopted DHIS2 NCD tracker to be able to increase screening of high-risk population, and we've been able to achieve 91%. Operational research study which was conducted on to be able to advance NCD's program is on cost of integrating chronic care for severe NCDs in the country, where we've been able to know how to allocate resources. We have, labor was taking like half of the budget for that, and also the treatment. We continue to do more research on how we can integrate NCD's healthcare services at district level, and currently, due to this research, we've been able to decentralize management of some of the NCDs, hypertension and CVDs at district level. Same with oncology. We've been able to decentralize hormonal therapy for breast cancer at district level due to different evidences generated. Coming to mental health services in Rwanda, also been able to generate different evidences which informed strategies such as prevalence of mental health disorders in the country, and this has enabled the country to establish a decentralized plan for mental health care services across countries. Not only that, also PTSD is one of mental health disorder which kept being a burden due to the tragedy that happened in 1994, where especially in genocide survivors, where PTSD was estimated to 37%. Due to this, different interventions were introduced, such as community engagement in using different approach to really targeting those people who are at risk and who are affected, and we've been able to introduce different psychotherapy intervention in the community due to different evidences. So not only that different services are being decentralized, and also infrastructure are being expanded, such as the recent one, Kigali Medical Health Center, which is not only working on a clinic, but also research and education is embedded on that. Also, we did some research to inform our healthcare financing policy through operational research. As you may know, the mutual scheme was introduced in 2008, and as the years progressed, and when we evaluated, we found that the poorest people were not able to access healthcare as expected. And due to this research, also we've been able to, the government has subsidized premiums and copayment of poorest Rwandans. Other innovations through RBC and Research Innovation Department, we lead clinical trials capabilities development in the country. And recently we hosted, in collaboration with the University of Rwanda, we trained the first cohort of health professionals and clinicians who are going to help boost clinical trial capabilities in the health facilities. And also we've been able to establish a plan for building 31 clinical research centers in the country, at least to serve one clinical research center to serve 500 population. Again, we have a data for health impact program where we train our team to use data use and generate policy brief every year and disseminate together with partners, WHO, UNICEF, and others. We also host our Rwanda Public Health Bulletin, which informs on quarterly basis different public health opinions in our setting. Also, we are trying to combine operational research and other advanced medical research, linking towards precision medicine, and we've been able to identify different perceptions on adaptation or implementation of precision medicine in the country. With that study, we've started also to really promote other types of research, including biomedical research. These are some of the examples of research which are now being conducted to really combine different types of research to achieve better health outcome. This is one which was conducted in genocide survivors to look how genocide has impacted their biological functions, looking at DNA methylation. And we found that DNA was closely, in utero genocide exposure was closely exposed, linked with different epigenetic marks which were discovered. And with that, also, we expanded this program of epigenetics to link it with other different diseases such as NTDs, podoconiosis, Also, we are exploring how epigenetics play a role in podoconiosis etiology in the country. Also, we are studying epigenetics linked with breast cancer in Rwanda, and this also is an important way to really try to move and link operational research and other advanced medical research in the country. We have many partnerships in that process, including private sector, WHO, and other different academic institutions. I thank you so much for your attention.
Thank you very much, Dr. Clarice. I have to stress this one out to speakers, but also to listeners. I forgot to say that we have a dessert session. So at the end of the presentations, we are going to have a Q&A session. And I would like to ask you to keep the questions and comments to the speakers. But I would also like to remind the speakers that we are running out of time. We are running around 35 minutes behind schedule. So I'll ask the next speakers to be really mindful about the time and not go beyond 10, 15 minutes of your presentation. So allow me to introduce the next speaker, who is Professor Musoka Fala, who is the Acting Director of Science and Innovation, Program Manager of Saving Lives and Livelihoods Initiative at Africa CDC. And he's a former consultant on pandemic diagnostics, World Bank, and a visiting lecturer at Harvard Medical School. Very welcome, Prof. Musoka.
You will have to move this. Okay. Thank you very much for the introduction. I'm very fortunate I've had two brilliant speakers, and they are taking all of my topics. So I have just to summarize for you. Thank you very much. I thought I would start by sharing with you the structure of the Science and Innovation Directory within Africa CDC, most especially when I listen to Clarice on the issue of operational research. We have a whole division of health system. So thank you so much. We have the division clinical trial and R&D, but without wasting much time, I was asked to speak on preclinical trial and disease control. As our first speaker said, a combination of factors increase our risks to outbreaks on the continent, climate change, human trial. For the last 11 years, those that were involved in the 2014 Ebola outbreak have seen changes, intensity in outbreaks. WHO Afro have shown that there are 2 outbreaks per week in Africa. Just this year alone, we've already reported outbreaks of filoviruses and arboviruses. But this is not the issue. The main issue is that in almost all of the outbreaks over the last 10, 11 years, we have now had medical countermeasure in a timely fashion. This is a slide from WHO where they clearly show that in the last 9 years, at least we can predict with certainty that every year there will be a filovirus outbreak, either Marburg or Ebola. We're here in September for the Marburg outbreak. All of a sudden, there was Marburg outbreak in Tanzania. We flew to Tanzania. While in the middle of helping Tanzania to respond, I got a call that I had to jump on a plane to report to Uganda because migrant was coming. We had Ebola Sudan in Uganda. This slide is very telling and expressing the 2014 Ebola outbreak in West Africa. When the Ebola Zaire hit West Africa, there were no treatment, there were no vaccines. By the time we built the system and the infrastructure, because I was presently involved in this trial, to introduce the Ebola vaccines, the outbreak had burned itself out. There were no treatments and there were no vaccines. So at the end of Ebola Zaire, we went to multiple meetings across the globe, and we're saying that Ebola Sudan is a strain. We should watch Ebola Sudan. Definitely there will be an outbreak. In 2022, 8 years later, the story repeats itself. Ebola Sudan was confirmed in Uganda. There was no treatment, no vaccines, and again, the outbreak went itself out. So whenever there is an epidemic, you expect two scenarios. Either we intervene with medical countermeasures and control the outbreak, or the outbreak ends. But when the outbreak resolves itself, what it does is that there will be devastation. It kills as many persons as possible. But Africa, we have not succeeded in medical countermeasures to be deployed in a timely fashion. The most sad news is this article that came from Cameroon, where they look at Mpox over 43 years, sequence Mpox. The sad thing is that over the last 50 years, we have had repeated Mpox outbreak in Central and West Africa. 2 weeks ago, a friend wrote me from Liberia and said, Musoka, my friend has Mpox. They say you are the expert. What should I recommend for treatment? And I said, unfortunately, there is no treatment. So Africa is vulnerable to continuous outbreak. The intensity, the frequency is increasing, yet we are so disadvantaged in all of these outbreaks. These outbreaks tend to burn themselves out. This is the 2024-2025 Mpox outbreak. When Africa CDC declared the public emergency of continental security, followed by WHO, Dr. Nikis in this hall and I and a few others were deployed to DRC to help to coordinate the response, the continental response to Mpox. When we arrived, we had around 13 countries. As we speak today, there are over 25 countries with confirmed cases of Mpox. It is sad to note that there is no treatment for Mpox. For those who are going through the experience, they have excruciating pains. We can't do anything for them. The vaccines we have were really not meant for Mpox. They were meant for smallpox. So as a continent, as a people, we are very vulnerable to outbreaks, but the sad thing, the power of R&D has not been exploited to the fullest to help us meet these outbreaks and pandemics. It is affecting us. Our vulnerability to outbreaks and epidemics is one, but imagine the sad situation we have. A continent of 1.4, 1.5 billion people, similar to India, similar to China, imports 99% of its vaccines, 95% of its diagnostics, and very limited therapeutics. The sad news is this. After the United States, China and India are the next two largest producers of pharmaceutical products, same as our continent, but we are disadvantaged. Our colleagues from the local manufacturing have done some studies to look at 5 other diseases in addition to vaccine-related diseases. And they clearly have shown that we'll continue to see increases in diabetics, NCD, my colleague spoke about HIV, malaria, of course, NTDs are called NTDs because they are African disease, and tuberculosis. Imagine the need for therapeutics and treatment across these diseases on the continent, and yet our ability to manufacture, to lead R&D effectively is still limited, non-existent. But I told my friends, Africa will have to find means to support this R&D as partners help us. But the way we've been presenting to our politicians about life safe, we have to bring the economic argument. So this is the slide from India to show that there are economic potential in addition to reducing our vulnerability to outbreaks, reducing our disease burden. There is an economic argument. 2023, India pharma industry raised $50 billion. Look at that and see the GDP of most African countries. What the pharmaceutical industry in India raised in 1 year is equal to the GDP of about 15 countries in Africa. There is a projection that by 2030 to 2050, our population will be 1 in 3 persons on this planet will be an African. Our Africans are not seeing the opportunities, but the Indian pharma company has predicted that by 2030, the market will have grown from 50 million to 130 billion. By 2047, it will have grown to 450 billion. Imagine the youth we are producing in Africa no jobs. How much more if we turn and begin to invest in R&D for local manufacturing? What the economic transformation? So with support from CEPI, BMGF, and EDCTP to develop the clinical trial ecosystem, we've done an extensive SWOT analysis of what are our challenges. We have clinical research capacity that are spread across the continent. There are other platforms that we soon can work in Africa. But in terms of weaknesses, as we say over and again, is that I was asked to speak on preclinical research. It's one of the weakest links. It's extremely weak. Our R&D infrastructures are limited. Most importantly is our investment as nations in R&D is extremely limited. The Alger Declaration has asked countries to contribute to 2% of their health budget for R&D. Up to present, only 2 countries in Africa have invested in R&D. If we look here, there are opportunities because we have the mRNA vector-based platform. We've been discussing with BioNTech, Moderna, and other actors how we can use mRNA technology to look after epidemics and chronic diseases on the continent. But we see that a major threat is that the entire African continent are over-reliant on foreign funding for R&D. How we want to resolve this are critical issues. I was asked to speak on preclinical issues and how we can address emerging threats and diseases. So we are doing a scoping analysis on where we stand in the entire clinical trial landscape, from basic science, translational science, preclinical to clinical research. If you look here, you can see almost all of the major interventions that we need, they are very poor on the continent. Something has to happen. Something has to change. We are vulnerable, increasing diseases, and there are huge economic opportunities that Africans are not exploiting. So what are we doing as Africa CDC? So we do know that preclinical research is weak. We are outsourcing. Issue of CROs are limited. Discovery science translational research is limited because of limited human capacity. So how are we building a continental global partnership to address these issues? So we realize that there are fundamental issues, system and process issues that has to be addressed if we move forward with developing R&D landscape, including preclinical, to support local manufacturing. One, the issue of governance, coordination, fragmentation, limited scientific talent, and lack of funding. So last year, we brought together 132 scientists from 43 African countries to say we need to be able to find a way to take R&D at the highest level of the African Union, at the level of the presidency and the ministers to be able to address. After 3 days of deliberation by the scientists, we created this research governance to be headed by a president and ministers to come together to lead research governance, and we build a strategic partnership. We published this in Lancet. The second thing we said that there's so much fragmentation, there are so much talents on this continent. Listen to my colleague from RBC present this very brilliant data. Tells me there are a lot of talents, but they are hidden and spread apart. So we decided to bring these scientists together and say, how do we work together to address these fundamental issues? So what we've done basically is to now take these scientists and put them into different areas of interest to the country, and then have scientists across the continent to speak on different issues, develop the way to go forward, address the issue in the landscape. The next thing we wanted to do was to map out the capacity that already exists on the continent. Because of time, we'll move quickly. This is what we have shown in West Africa. We have identified, with support from CEPI, we have identified 173 clinical research sites in 13 of the countries. We've seen that on the continent, there are phase 1, phase 2, phase 3 trial sites on the continent. We see that there are basic research sites on the continent, so there are resources that we need to explore. How do we develop the workforce? We are taking a 3-pronged approach to develop the workforce, working with partners to invest in master's through PhD scientist program, but we want to take one step further to support our physician scientists and our pharmacy scientists on the continent, so working with multiple universities. A lot of partners we've been discussing this, how to move forward. How do we support senior PhD researchers so that they can be routine? We think that there's a need for their presence in the industry. These are the expectations we set in the next 2 to 3 years. to see how do we work across multiple universities. It's telling to know that University of Rwanda is involved with the Public Health Institute to address this issue. No matter how much we do, if we don't invest in our R&D system, we'll not succeed. So what we have done now is to develop a 5-year strategic plan and an investment case. We are now working with international donors. We are working with a few countries, the heads of states of a few countries, to call a meeting to present the R&D investment case and give them the reason why Africa must invest, at minimum to meet the 2% Alger declaration, and then to be able to harness innovative financing. To summarize, R&D is critical, it's urgently needed. Our continent is vulnerable. Even from an economic perspective, R&D will help us, but we know that there are issues with clinical trial, discovery, and research because of limited human capacity. This is critical. We need to link together and work together. So this investment and partnership to build a clinical trial ecosystem supported by good friends like CEPI, EDCTP, and WHO, BMGF is working together. We are around and available to talk to scientists to join us to plug in one of these initiatives. But the time is now. We've now been very advantageous to move quickly to outbreak. And so we are involved. There is no time for me to speak on some of the research we are doing across multiple outbreaks, mpox, now partnering with CEPI for chikungunya in Kenya. This is where we stand. There are challenges, but we can turn these challenges to opportunities. Thank you very much.
Thank you very much. The next speaker is Prof. Leon Mutesa. He's a professor of human genetics at the University of Rwanda, and he has more than 15 years in academia, building capacity in research, clinical research in genomics and genetics. And very welcome, Professor.
Thank you very much for the nice introduction. So, mine is just about I've been just asked to talk about the innovation in clinical research and especially addressing the health system gaps, building upon the case of Rwanda. We all know that the high morbidity is happening, especially in African continent, where we see also a link with disease, including zoonotic conditions. We have seen the Marburg. So we all know that there are also still this gap in terms of clinical trials. We've limited the resources, in terms, especially in terms of human capabilities. But also, as other speakers have been emphasizing, limited infrastructure and funding for R&D is also an issue. All of this we want just to fit the gap between the health care solution and the evidence that we generate from different implementation research that we want to do, especially in African continent, to be self-independent. So as a Rwandan model, we have seen some of the examples from the RBC, where we see the emerging leader coming from this country, but also informing the policies, but also being a model in Africa, and also having some of the homegrown solution in different disease conditions that have been presented by different speakers previously. So, and also there is also a clinical research ecosystem being built here, where we see the regulatory framework in place, the government support, the academia involvement, and also partnership from different partners, including EDCTP, for example, funding some of the good research projects in Africa, but especially in Rwanda as well. I want to skip this because it has been also emphasized by RBC, where we see the major funding coming from, have been heavily coming from different organizations like NIH, Gates Foundation, and others. So even this one, you have seen the initiative to build the vaccine by manufacturing in the country, as it has been just slightly mentioned by the speakers from RBC, where we see some of the good initiatives of having the creation of clinical trial sites in the country, just to respond to some of the gaps that we have, not only in Rwanda, but also outside Rwanda. So we also have, this is some of the recent learns that have been also presented here that I want also to emphasize, to show some of the innovations that can just drive the solution that African scientists can build upon to be self-independent. So pandemic, we had some of the ground solution. Remember, it was very difficult just to test during this pandemic. Some of the African countries could not have access to solutions for testing. So in Rwanda, we had this, for example, this technology that we invent save the cost, but also accelerated the control of pandemic at that time by having the technology called pooling, where we could just mix the samples before just testing it, but also save the cost in terms of the PCR cost we had just to spend for testing one by one. And then you could see how we could just save the time, but also the resources, only testing those cases. You can see from this picture, one pool size, which was only positive, but others were negative. Then you could just accelerate the response to the COVID. But this technology was very efficient. It could also be scaled up with the high sensitivity and specificity. And we scaled up this technology across the country, and rapidly we also shared the information with the international scientific community. And in the case of the country, just controlling the pandemic, we could quickly address the issue of identifying the positive cases, but also treating the cases very quickly, but also controlling the pandemic on the entry points, like airports, other entry points, but also during that time to see how we can control even the new variant which are being introduced at that time. We also build upon that reason to respond quickly during the Marburg last year, which was also the case. I don't have a slide here. That's to show you that we build upon those experience to come up with some of the innovative solutions that can support the country, but also the continent, to address the issue of the gap between the different research, clinical research, and vaccine by manufacturing, for example, and clinical design, and other infrastructure that have been just mentioned here. Here I want just to show you some of the flagship projects that we have built upon after that recent land. You see, for example, in this country, we have the first vaccine by manufacturing plant, which is going to be one of the infrastructure that can scientists just based on to have some of the solutions that I mentioned here. So you see some of the initiative happening here during the last 2-3 years, and also the opportunity we have to host some of the big companies or organizations like International Vaccine Institute, AMA as well. And then when you zoom in, you see the ecosystem for vaccine by manufacturing is very complete. And then what's missing is just the capacity for human to be able to do some of the different innovation that I mentioned here. So I mentioned that the big issue is just to also have the resources, the funding to be able to establish the infrastructure that can just support the initiative of good ideas that scientists in Africa they have. So one of the strategies we have is also to mobilize the resources through the research grant. You can see some of the big international funding institutions that heavily fund in African just for having some of the independence in terms of research, the design and implementation. Here, I just want to mention one of the ongoing research programs that we are having in Rwanda, where the Team Europe Initiative designed a program called Manufacturing Access to Vaccine, MAVPRAS, with a focus to strengthen by manufacturing the vaccine capacity in Rwanda. And then we designed this program, which will be also example. This program is very ambitious. Is one of the few. This program is very ambitious. Is one of the few on the continent with a very comprehensive program with outcome, with different masters and a PhD in different domains: clinical trial, diagnostic immunology, infectious disease, human genetics, genomics, therapeutics, and the drugs, especially experimental medicine, where we can start now doing some preclinical studies here. So this is this is a program which is underway, under development. As of now, we are expecting just to have this program accredited by the High Authority, Higher Education Council here in Rwanda, and then to be able to start by the next academic year. And then it will be beneficial for different, not only Rwandans, but also other African scientists, and to come up with the good skills that we're lacking. So we here want just to mention some of the good outcome from this program that we are looking for. The implementation of a preclinical trial study and facility and also clinical trial. We all know that most of the countries in Africa, they can't have access to preclinical trials because they don't have just the facility, the skills. Most of the study, they start by phase 1, phase 2 onwards. But when you look at this picture, the preclinical is still a gap. So one of the objectives of this program is just to fill this gap and then to propose to the African scientists some of the good access to the skills for preclinical trial studies, and then be able just to have all end-to-end clinical trial studies being done in Africa, without just sending some of the knowledge we have outside. Of course, we are targeting to start with some of the models we have in these preclinical trials, in animal models, building a small but very complete facility for animal models lab, and with a focus, as I mentioned, of course, to present to the government, and also other scientists in the country, but outside the country, some of the solutions for vaccine safety testing, but also other use of animal models in the biopharmaceutical productions. Also another program which is already running, also producing the good scientists, is just this biotechnology program funded by EU, as I mentioned, where we have an ambition program to have at least 125 masters graduating by 2027. Same for PhDs, at least 25 PhD by 2027. This is just happening now. And I also want to skip this. We also follow the government research agenda to combine with the effort that I mentioned with this different initiative. I just want to finish here by saying that the cross-cutting areas to support the health research initiative with capacity building in R&D, but also cutting edge in technology, where we see different programs, including even artificial intelligence, that we are trying just to combine to have some programs for developing the skills and the capacity building in the country, but also can be beneficial from other African countries as well. Okay, let me stop by here, but also acknowledging some of the support from different partners, especially European Union, government of Rwanda, and other partners like Expertise France and the SIDA program from Sweden. Thank you very much for your attention.
Sorry for the pressure. Thank you very much for the presentation. The last but not least speaker is Professor Nikes Ndembi from the IVI. He's the Deputy Director General and the Regional Director for Africa. And he's going to talk about research and development for domestic vaccine production in Africa. Very welcome, Prof. Ndembi.
Good. Okay. So I think everything's been said here, so I'm going to be very brief, straight to the point. So 3 really key areas here. First, to start, thanks to the organizer, very well organized session. Second, I have my lecturers, those who actually put in those thoughts, Professor Bacham in the room, the partners and all. Really, I think it's a great pleasure to be here in Kigali. So I think let's get started. I'm going to talk a little bit what the International Vaccine Institute, I think Prof. Leo Muteza really did justice to what we're doing globally and also in Africa. And thanks to Professor Musoka as well. The framework for action that we developed at Africa CDC, really at the continental level, now we want to bring it to our member state. And lastly, what does it really take for the continent? I think some of those have really been alluded to. We need to put money into financing, domestic resource mobilization, being sure that we own the research. Priority research should be from the continent to be able to drive all these good presentations and innovation that our colleagues from the RBC have mentioned. So I'm going to skip this for the interest of time, but this is our footprint. We're represented globally, and most of these, I think this is probably the unique organization that works from discovery, development, delivery of vaccines. So some of the vaccines, you know them. The cholera vaccine was developed by our institute. I think this is important. We really talk what we do, and we do really what we actually say. So if you look at the footprint on the continent, most of the diseases we're tackling are the diseases that you know. Cholera is unbelievable that we still have outbreaks of cholera on this continent. More than 15 countries on the continent, if you look at the Africa CDC report, are actually reporting outbreaks of cholera. I think this is something we need to stop. What is the problem? I think we need to start looking innovatively and see how we put the research that you're actually lecturing to our students in school into practice. So that's the footprint. We are based in Africa, here, Kigali, a beautiful city. And then our country office, Dr. Ondari is there somewhere, is the lead for the Kenya office, also based in Europe, in Sweden, and a country office in Austria, also in Hong Kong, where we have one of the largest laboratory for pandemic prevention, preparedness, and response. So I think that's more than 100 projects, more than 44 sites, more than 1,000 jobs generated based on our research, development, and innovation. So that's the footprint. If you look at it, the map, we have 3 states, Kenya, that's why we have a country office there, Liberia and Rwanda, that are actually signatories, set parties, 2 signatories, Egypt and Senegal. You know very well Senegal with the capability and capacity that they are putting at IPD for yellow fever vaccines over 80 years ago. So this country, we can do great things on this continent. So 9 countries with expressed interest to join the largest family for IVI, more than 23 project host countries. So now, I think it's important. The continent, we agreed. Dr. Musoka mentioned it. Coming from COVID, I think I'm privileged to this. From my office, with the support of the Musoka and all that, we developed the continental framework for action. It became difficult and imperative for this continent of 1.5 billion people, having mobilized $2 billion not to get access to vaccine. It was shocking. It means that we need to think carefully where we put our resources, build capability to be able to really respond in period of emergencies. So what does that entail? The head of state have endorsed it. They all agree we need to do something. At the time of the COVID-19 pandemic, only 1%, Dr. Musoka mentioned it, all vaccines that have been administered were produced on this continent. That's the same with therapeutics, that's the same with diagnostic. You cannot respond to outbreaks, to pandemic, where you don't have the appropriate tools. If you don't test, you don't detect, you don't prevent, what are you responding to? That's very important. So we had to put really look into that carefully. So the target, which we're making significant progress thanks to the African cities and other partners, the target is to 30% at least by 2030. I think there's a good traction there. And then by 2040, this continent should be able to produce 60% of all vaccines that we're using for childhood immunization and all. When I say 60%, maybe people don't get it. If you go to a vaccination facility, if there are 100 vaccines being administered, only one likely to be produced on this continent. That's what it means. So we know the enablers from the framework for action, very clear. Financing, we need demand certainty. The manufacturers need to be really sure that there's enough volume. The economy of scale. We need to produce, but need people to really be sure that we absorb those vaccines. We need to increase tech transfer and IP, and this cannot come without research and development. It means that we need to invest. We need to build capabilities in terms of regulatory system. We're taking really good shape. Those days during COVID, we only had 2 countries or regulators that have achieved maturity level 3. Now we are 8. I think this is going to move, and then we're increasing that reliance and ensure that the product made in Africa can be accepted all over the world. And in the case, for the case of yellow fever, the vaccine produced from the Institute Pasteur of Dakar is being used all over the world. This is important, that the product should be accepted by whoever and then wherever in the world. Though we need to increase infrastructure, research and development, being sure that we train. I think it came in all the presentation. Talent development is important. And then also infrastructure. But more so, again, to the previous speakers, avoid fragmentation of the ecosystem. I think this is our problem. There are researchers next door. Some is doing next-gen sequencing. The next one next door is shipping the sample somewhere. We need to talk. Cross-fertilization, sharing resources, collaborating. That's very important for the development of this beautiful continent. So where are we on the African vaccine manufacturing landscape? So just look at the map. Where you see, if you are not seeing, let me know, a black filled dot cycle, it means that that is where there's a facility. I'm not talking of a container or a mobile. That's where there's a facility with a tech transfer agreement, because that's the only way you can manufacture. Then where you have those blue ones, it means they have the facility, but there's no tech transfer. All is being signed or negotiated. Where there's a white spot, it means that there's a huge potential. There could be actually not facility, maybe a bio container, but again, probably no tech transfer. That's extremely important. And that tech transfer, that is the key. The constant variable here cannot come, it comes at a price. You have to invest. I mean, you have heard from me, invest at least 100 times already. You need to invest to be able to own your space in terms of research and IP. So the good news is that we at least have 8 antigens from the 25 African vaccine manufacturers that we have actually sampled across, thanks to the African CDC, China, and then PAFT with this good report. It gives you a little bit of perspective. By 2030, if everything goes well, the timelines, at least the 8 products, but again, only 2 African countries. Means South Africa and Senegal. So we need to really move at speed. The next pandemic can be here tomorrow, and we might not be ready, but at least we have where to start with. So what does it take really from the manufacturing perspective and vaccine to really produce vaccines? Okay, so this is a really riding on the previous speakers. They all mentioned, I'm going to skip this slide, but this one is what I want to, is another visual representation, what Prof. Leo mentioned, what Dr. Prof. Mosoka mentioned, what the presentation from RBC is like a summary. If you look at the orange stars, okay, this is not on the continent. It's not happening here. The green stars is what we can do. Out of the 5 stars on that upstream, we only do one. And someone, even at some point, the animal models, thanks to Math Plus, we don't do anything at all. What does that mean? It means that we cannot manufacture, really. We're going to continue doing fill and finish. You know what fill and finish is? You get a bottle, you just fill and you cap. That's not manufacturing for me. We need to do drug substance. And this is going to come probably the second. IPD is the first on the continent doing drug substance. The second going to be from IVI with the tech transfer to Biovac in South Africa. That's where really we are bringing the technology to the continent. Being sure a disease like cholera, we should be able to produce locally, address the local demand for the local people. So we did also an analysis and say, who is actually funding these things? What are we doing? What our government are doing in response to this? After the framework for action, which is a blueprint, there should be a vehicle to fund it. But have we presented a document or a budget to our head of state? They said we don't have the money to be able to cover that. I think this is where the scientists, we need to really be proactive. Again, thanks Mosoka for that. We need to call a continental conference, bring a head of state to really brief them what it takes to manufacture, how we need to invest into this space. So this slide summarizes what is happening in the global north and what is happening currently on the continent. If you don't see anything, just look at the red ones. The upper one, you can see a level of mix between the private sector, the government, and all partners. But when you come on the continent, who own it, the space? Is the private sector. This is not good, except the regulatory. So the government, we have to step in on this space. This is a matter of health security. Okay, so that's important. That's a model that we need to look at. How do we blend it? Government, private sector, industry to make it happen. I'll give you an example. So this is IVI, the way we do business. You look clearly here, we have the industry. Our HQ is in Korea, the Korean government across the globe, the global health actors, the like of CEPI, WHO. The lesson, the philanthropists here is that we work with everyone. And that's very important. If you want to build, that goes into the collaboration we're all advocating for. And it's important. Even in the response to any outbreaks, cholera, Marburg, and all, you have seen RBC, collaboration. You need partnership, you need people, you need policies. You need to be able to do a little bit of politics in some of those things. And it's important because that's the way the world is built. So these are 3 vaccines from our portfolio made from IVI with funding from different partners. The first one is the cholera vaccine. If you don't see again, the cost is $28 million for the development. This is the cheapest. The message I'm passing here is that it's not cheap to manufacture vaccines. We know the enablers, but it's not cheap. And this can come from a large collaboration to be able to make it. If you look at our second vaccine developed in-house from IVI, again, that's our vaccine number 2, typhoid. $29 million. And this is the cheapest. Almost also cheap, around that figure. And one of the cheapest is vaccine 3 that you saw, the non-typhoidal salmonella shigella. But the point here, the numbers is that we need to invest. We need to stop with the donation. We need to be really partners putting contributions around the table and making really a case for more funding rather than being, continuous beggars over time. We need to change that. That's very important. I think the lessons are there with the current global architecture, geopolitics, and funding strain. So what are the solutions? Because there's no business model for the manufacturing currently on the continent. I'm going to give you a case, Korea, where our HQ is based. Korea, almost 10 years ago, was manufacturing 5% of their vaccine. We are 1% in Africa, so it's not a shame. They decided, based on the neighbors, the Japan, China, and all, to actually be self-sufficient. You know what they did? They actually had to come with a finance blended mechanism. You have 50% of all viable project, 50% of that budget from the Korean government, 25% from the Gates Foundation, which is a philanthropist, and then 25% from the industry. That is what we're asking. If you can get that 50% from a government, I'm sure every funder in the room would put money on the table because you are bringing and sharing the risk to be able to drive that. So some of the projects on the continent, I'm going to skip this, but again, Rift Valley with Afrigen, we're actually supporting Afrigen. We mobilize resources together, and then we take them really from the development to actually WHO PQ. That's one of the case studies. I mentioned BioVac, that's the same. By 2028, BioVac in South Africa should be able to manufacture an oral cholera vaccine made in Africa to meet really the demand and the gaps that we have observed for the past couple of years. So, in my conclusions, I think we have a lack of sufficient and appropriate R&D infrastructure. It can be argued. We do have centers of excellence, but they are not cross-talking. They are not networking. We need to really have a network of networks to be able to leverage those resources and put them really available to the young scientists to be able to drive their science and research across the continent. The lack of existing network, I mentioned already, the funding model. I mentioned the funding model already. And then the brain drain. I think for some of the professors at university, I can tell you, most of their students ended up somewhere. Because we are not providing conducive environment for the young scientists to be able to really put into practice what they've learned on this beautiful continent. So finally, this is the model we are proposing, an ecosystem, where you have everything. The industry, the regulators, and all of those talking and networking to be sure that the dream comes true. Again, thanks so much to my colleagues who are here, who flew from Seoul. Thanks to all the partners for what you're doing for this lovely continent. But it's a call, an appeal to a government to put money on the table to make research or Africa, what did we say again? Africa great again. Thank you so much.
So unfortunately, we are doing very bad on time, so I'll only allow one burning question, but I'll invite everyone to interact with the speakers during the break session. Can someone help us with a mic if we have one burning question to any of the speakers or to all of the speakers? There's a hand over there at the end, at the back. Yes.
Yeah, thank you very much for the opportunity. I'm Professor Omar Ibrahim of Environmental Change and Public Health. My question is to the Prof. Staying there. If we are at 1%, don't you think market is an issue? Who do you think is going to be the market for the African basin production? Thank you.
The question is for who? Sorry?
The professor there.
Oh, okay. You can just put on the mic.
No, I think that's a very important question. It's always been why do we have to manufacture? It's very important. First, it's not the market, it's a matter of health security, I mentioned first. But then second, when you look at the market here, we are actually representing $30 billion US market, the continent alone. So there's a market, we're talking of 1.5 billion. If you look at in terms of birth cohort, Nigeria alone, it's actually the third largest birth cohort after India and China. It means that there's actually a volume here. We need really just to be able to show that we have a mechanism. That's what Africa CDC is working in terms of pool procurement, aggregation, and being sure that our countries can buy vaccine made in Africa. That's not the problem in general. There's a market here.
Thank you very much. A round of applause to all the presenters. I'll have to give the floor back to the MC for the next steps. Thank you very much.
Thank you very much, Nadine. That was an amazing job moderating the session. Thanks to Albert and the entire RBC team for putting this event together. And thanks to you for being a wonderful audience. As Nadine said, all the speakers are still around. Please find time to interact with them. We are going to take a very short break. We will be stretching our legs, responding to those calls as we get the room ready for the opening ceremony, which will be coming up in a few minutes. So for now, we'll take a break, but we will be right back. Thank you so much.